Forget frequently asked questions.
Common sense, common knowledge, or Google.
How about advice from a real genius? 95% of people in any profession are good enough to be qualified and licensed. 5%
go above and beyond.
They become very good at what they do, but only
0.1%
are real geniuses. Richard Jacobs has made it his life's mission to find them for you. He hunts down and interviews geniuses in every field: sleep science, cancer, stem cells, ketogenic diets, and more. Here come the geniuses. This is the Finding Genius Podcast
with Richard Jacobs.
Hello, this is Richard Jacobs with the Finding Genius Podcast. I have Nikita Ved. She's a Novo Nordisk postdoctoral research fellow in Dr. Duncan Sparrow's group in the Department of Physiology, Anatomy, and Genetics. And we're going to be talking about her work. I could describe it, but I'll probably bungle it. So, Nikita, welcome. And if you would, just describe your research.
Hi, thank you for having me. So my research really focuses on how diabetes during pregnancy causes birth defects in the embryo. Focus on how it forms heart defect in the infant.
Yeah, my wife had gestational diabetes with our first child, but she was very careful and immediately changed her diet and ate well. And I guess hopefully the only consequence is that our daughter was a little bit heavier than other babies, but she seems to be okay. But I didn't realize the problems could be so large. So what happens when a mother has diabetes in pregnancy? What can happen?
So this is actually where a lot of things like this podcast can do a lot of help, because like you said, you didn't really know. Many people don't know that one of the major complications of diabetes, in addition to blindness and kidney disease, heart disease, is actually if being pregnant and having diabetes, because not only can it increase the rate of miscarriage by between 15 to 25%, but also increases the rate of your child having a birth defect. And so in particular with diabetes, it increases the rate of having any birth defect by up to 30%. And considering...
Yeah, that's huge.
Yeah, it's quite a lot. And this is defects of all kinds, not just heart defects.
Let me ask you a quick question here. Does science differentiate between women that have diabetes and then get pregnant versus ones that get it because they're pregnant, I guess, gestational diabetes?
So that's a very good question. It's tricky to recapitulate in the lab, because to induce diabetes in an in vivo model, for example, say using a rodent model or what have you, any drug you might do to artificially induce it ultimately would be harmful to the embryo anyway, the drug itself. An example is streptozotocin. It's commonly used to induce diabetes in rodents, let's say. Now, if you induce that in a pregnant mouse, the embryos will have defects regardless of maternal diabetes, because that drug is so toxic and crosses the placenta. So scientifically, we typically will use a model of pre-gestational diabetes, i.e. Someone having diabetes prior to conception. Now, clinically, of course, this is well delineated. You do get women that have diabetes prior to conception, and you do have those that develop it at pregnancy. But that too is complicated by the fact that many of these women may be borderline diabetic at the time of conception. They don't realize it because for whatever reason, for example, women are having babies later in life, and that's sort of around the time where one might develop type 2 diabetes, or they might be a little bit more sedentary and thus perhaps overweight. And again, not knowing they could be borderline, and that metabolic stress of being pregnant just pushes them over the edge.
Yeah, is it a different condition? I know the line is blurred, like you're saying, but does science recognize that the diabetes is different, or is it that the person was borderline and then they became diabetic while they were pregnant? Or is there such a thing where something happens in pregnancy and you're diabetic just for the pregnancy?
So gestational diabetes, traditional gestational diabetes, one that isn't, say, blurred by being borderline at the time of conception, will typically disappear when the baby is born. That is just a temporary metabolic disturbance. However, these women are more predisposed to developing type 2 diabetes later on, or gestational diabetes again in additional pregnancies. But like you said before, clinically, can you see between the blurred lines? It's a little bit tricky to know if a woman is borderline at the time of conception, because many women don't really know when they have conceived. In fact, around 40% of pregnancies are unintended. And thus, many women might not know to check their blood glucose or their metabolic state until well into the pregnancy.
Huh. Interesting. So, yeah, this is tough. I mean, I was going to ask you, what if you just get data on thousands of women that appeared to be at least pre-diabetic, and, were their conception rates different? Were their babies born healthy or not, versus women that, were just appeared to be normal and then, got gestational diabetes? I mean, I don't know if there's enough reported data out there already, so you don't have to just focus on mice, but is there?
There are some data on this. The trouble is that many different countries will specify gestational diabetes slightly differently. Additionally, those that develop gestational diabetes, sometimes the follow through in the clinic isn't necessarily great due to, say, socioeconomic circumstances or whatever. So the data are out. The data is out there. It's just difficult to unpick as well. And so that's why, and whilst we know, like I said, the data's out there, we know that diabetes in pregnancy, regardless of its form, either gestational or pre-gestational, causes defects. The real question is why it causes these defects. Some evidence shows that gestational diabetes and pre-existing diabetes exert different effects on the outcome of the infant, but that study really needs to be looked into further.
And I was going to ask you, what does diabetes look like, throughout the gestation period? But I guess the first probably 12 weeks are completely hidden. Because like you said, a lot of women don't even know that they're pregnant. And I would guess maybe the best data is, the last trimester. Like, what does the data look like? What happens to the typical fetus when a woman is diabetic, by whatever mechanism is that being studied?
So this is where it gets quite complicated. Gestational diabetes isn't tested for, as you may have experienced, until well into the second trimester of the pregnancy. Now, the formation of birth defects occurs well into the first trimester, if not the first 7 to 9 weeks of pregnancy. So there is a disconnect here between when women are tested and when these defects are actually occurring. And so for many women, the damage may already be done by the time they're tested, and they may not necessarily be able to reverse it.
Yeah, I remember with our second child, my wife said, you know what, I'm just going to assume that I have it, and I'm going to eat as best I can. Because the doctor wouldn't even test her. He's like, no, the protocol is to wait until this time, and, your sugar has to be at this level, and blah, blah. And she's like, I'm not waiting. I'm just going to do it. So, yeah, it seems to be not helpful the way the testing's done right now anyway.
Absolutely not. In fact, I wish you could see me rolling my eyes, because this is something that, again, I'm trying to change if I can through doing as much public engagement as possible, talking to a lot of clinicians, seeing if they will perhaps change protocol, because testing women so late into pregnancy is I think it's actually very damaging. There are other ways to look for metabolic disturbance beyond an oral glucose tolerance test, which is what I'm assuming your wife had to do. They gave her
exactly.
Yeah. There are other ways of doing it. There are better ways of doing it. And I think ultimately this will save lives. And even if, say, this will also help the mother enormously, because, the stress that this puts on parents, an infant being born with a defect, the infant itself obviously may have to have multiple surgeries, lifelong care. They may find it difficult to assimilate with their peers, but also on the parents. This is an enormous emotional strain for them.
Yeah, I mean, I wonder what percentage of the, I've heard on first-time pregnancies, the miscarriage rate is very high, and then, once you have a child, for some reason, it seems to be a lot lower after that. But I just wonder what percentage of the miscarriage rate in general or overall is caused by the spontaneousness of the diabetes causing it.
That's tricky there, because we don't necessarily have information on, we don't know actually whether the diabetes is causing a miscarriage because there is such a severe defect with the embryo that it's not compatible with life and is spontaneously terminated, or it's causing a uterine defect, let's say, and thus the very early embryo, the blastocyst, is not able to either attach or stick around, basically. So that is also we don't know which is the underlying problem for that.
Would it be possible to do a study where pregnant women at a certain stage volunteer to eat a certain way, or they're already eating a certain way and they're reporting, and you can find enough difference in the way enough of them are eating to make a study out of that, or do you think it would be confounded by too many variables?
So there was a similar study on what you suggested. I think it was done in France some years ago, and they attempted to look at the diet of many pregnant women, and they tried to monitor their health, their pregnancy, and the overall outcome of the pregnancy. And it seems that those from I suppose, a lower socioeconomic background, they typically ate cheaper, faster food than those that were perhaps more middle class, more affluent. And it's also further complicated by the fact that some women have to work till very late in the pregnancy. And so that can add onto stress, which can also complicate things further.
Okay. So what kind of defects seem to be predominant when women are diabetic during pregnancy? So
the most common defect seen in infants of diabetic mothers are typically congenital heart defects. So that is when so a congenital heart defect is an abnormality within the structure of the heart that is formed in utero, so before birth. And it can comprise of many different kinds of defects, including a defective heart valve, a defect in the wall between your ventricles, so that's called a ventricular septal defect, or one between your two atria, so an atrial septal defect, abnormalities in the heart muscle. But the most common congenital heart defect is a hole in the heart, typically in the ventricular septum. And that is problematic because you have a mixing of oxygenated and deoxygenated blood, which will ultimately cause a defect in circulation, potentially heart failure, and potentially death.
What about longitudinally looking at, people born with these defects? Do they tend to have heart murmurs? Do they tend to have, are all the problems acute and early? And are we even looking at 20, 30, 40 years down the road, what's happened to them? Or is that just, we're not there yet?
So we're getting there. So yeah, many of these patients will typically have a heart murmur. But a lot of these more severe abnormalities will be treated by surgery, several surgical interventions. And we're only just really seeing these patients in their later years now, where we can see additional defects forming. Again, cardiomyopathy, heart failure, but the numbers are very low to make a definitive observation.
So is anyone able to provide at least guidance, a statement that says, if you're sexually active and you have any intention at all of getting pregnant, the time is now to eat as best you can, whatever that is allowed to be defined as, because that's the critical time to make sure you have a healthy baby?
Yes and no. You'd really look to your national diabetes charities for this advice. So Diabetes UK, at one point on their website, did state that if you are diabetic and sexually active, you should consider, if you're not considering having a baby, you should definitely invest in more protection. However, I think people would benefit more from there being a wider campaign and not just looking to a very obscure website if they're not necessarily diabetic. Perhaps they could be have a high body mass index and thus could be leaning towards diabetes. This information should be out there. And this is what I'm trying to work on as well. I'm trying to get this information out there as much as I possibly can. Because again, according to the World Health Organization, 1 in 3 women with diabetes are of reproductive age, i.e. they are at the right age to conceive. So if these women aren't necessarily informed, we could see a huge rise in birth defects in the future.
Yeah, well, why do you think that this is not being paid attention to very much? And do you think it's actually being dismissed by people's doctors, or you'll be fine? Or what do you think happens in the clinical setting nowadays?
That's a very good. I think with diabetes, there are some people assume there are much bigger fish to fry. Trying to treat the disease itself, trying to treat all the other complications. For example, diabetic blindness is the most prevalent complication of diabetes. And to be honest, more people will care about their vision. It's something that more people can relate to, losing your sight versus perhaps someone's baby not being born okay. Perhaps it's not necessarily very relatable. However, everybody knows someone that's had a child. and everybody knows someone that's diabetic. So I feel like it should be relatable. It should gain more visibility. I'm not really sure why it isn't, perhaps because, again, we know it happens, but the why is so complicated that perhaps people aren't, I don't know, they're giving up.
Well, I haven't experienced it, and I forget what my wife told me. When you get pregnant, I mean, a lot of stuff changes. So your blood volume increases a lot, and I mean, all kinds of stuff changes. I'm sure later on more than early, but are any of these changes, does that help at that time to say to the woman, hey, a lot of stuff's changing. You may feel this, that, and the other. Now's the time to really, pay attention to everything that's happening with you and look for these particular signs that would tell you you're having blood sugar problems. I mean, is there any, do the, I guess they call it symptoms of pregnancy, do they mask what people would feel are the complications of diabetes, or do they heighten it?
It would probably mask it. The common traits of diabetes are tiredness, thirst, changes in weight. You would notice it as well. So you might think, well, I'm fatigued because I'm really thirsty because I am pregnant. But so this could be one of the reasons why people don't really spot the changes in themselves earlier. But I also think there is a really woeful lack of public education in this from the public health sector. I think as our society is becoming increasingly diabetic, I mean, the World Health Organization predicts that by 2045, around 630 million people globally will be affected by diabetes. And that's a massive jump from 425 million people now. So with an increasingly sedentary population, and diabetes has a heritable characteristic, we are going to see more people becoming diabetic. These numbers aren't going to get any lower. Infants with birth defects will probably rise. And so public education needs to be improved. I think the best way to do it would be to start with, well, I think when women go for health checks or physicals or anything like that, when they're of reproductive age, I think this should be part of their exam, I suppose.
Well, what happens when, I don't know if you know, but when a woman's pregnant, how does their perception of food change? I've heard about cravings, but I don't know if it happens early on or later. I just don't remember. But again, do women that when they first become pregnant, do they crave, let's say, things that would worsen their diabetes, or do they, tend to crave healthier stuff? I mean, is there a compounding effect there?
So my knowledge on cravings and pregnancy is very limited, but anecdotally, I'm speaking of friends that have them, it's all over the place. Sometimes they'll crave something that's healthy and they'll think it's they're having a craving because of this particular point in their fetus's development, or sometimes they'll crave something bonkers and there's no real rhyme or reason why. One thing though that is problematic is that a lot of women still think they need to eat for two, and that's a myth. You don't need to eat for two, especially in the earlier stages of pregnancy. In fact, I suppose the time to eat more is probably once you've had the baby, because breastfeeding increases the need for the woman to increase their calorie content by up to 500 calories a day sometimes.
So what do you think are going to be the, I don't know, I mean, this is such a large, pervasive issue. What do you think are going to be the ways to, I don't know, make headway into it?
Well, I think I need to first thing publish my work, and then, but also I'd like to meet locally with I'd like to meet with Diabetes UK, for example. I'd like to meet with the British Heart Foundation and talk and discuss with them how we can publicize this wider, but not just stop here, perhaps maybe even work globally if I can. I mean, I'm just one person. Obviously, it wouldn't be just me. But if we could publicize this in any way we can and get people thinking about this, because the stats are crazy. I mean, in a few years ago, the only numbers I have available, 35,000 women in the UK had some sort of diabetes during pregnancy. And of that, 7% of those women had 7% of those infants of those women had birth defects.
Huh.
Yeah. And so the first thing I need to do is try and figure out why this happens. And if I can figure out the why, maybe I can stop it one way or another.
Yeah, well, we haven't talked much about that. What, I don't know, so far, what's your inkling, what's your experimentation say is the why?
That is still a little bit unclear, but so my research primarily focused how differing severities of diabetes, different types of defects, severity defect. So one thing I've uncovered severe, the mother's diabetes particularly, you're more likely to get heart defects, but you also get craniofacial and tube defects. So those are defects of the head, skull, jaw region, but also of the spinal cord. So you get the anencephaly, where there is, the brain grows outside the skull. You get spina bifida, where there is non-closure of the spine, and so the spine would also pouches out. You can get cleft palate, you can get cleft lip. There's a lot of other defects that come with this, with increasing severity of diabetes. But the most prevalent that I've seen in every severity, even the mildest forms, you see heart defects. And so
these are all pretty severe, disfiguring, and horrible for your health defects.
Absolutely. And so I'm trying to look at when these defects have concept, what is their unifying factor? It all seems to range back to a subpopulation of progenitor cells and perturbation of these. They form the heart and they form the brain and spinal cord. So I want to look at how these cells are disrupted by high blood sugar. And if I can really understand how they're affected by it, perhaps I can reverse engineer that.
When does the, I just don't know, when does the placenta form fully? At what point in the pregnancy?
Sorry, I didn't get you there.
Oh, when does the placenta form during pregnancy? Maybe there's a correlation there. Maybe it's not fully formed early on. And
I'm actually also investigating placental defects as well, my study. And it seems that, again, with increasing severity of diabetes, you're getting very poor placenta formation and vasculation, which could also be the reason why it gets these defects. It becomes a little bit complicated because then is the infant getting these defects because the placenta isn't properly formed, or is it getting these defects because of the maternal diabetes? It becomes a sort of, I suppose, chicken and egg scenario.
I don't know. Is there data on when would the placenta be observed in pregnant women? Is there any studies where they did look at, I don't know, changes in placenta or thickness or composition versus what happens to the baby?
There have been studies, but remember, if you're trying to look at it in utero, you don't have as much information as if you can look at it post-parturition, so after birth. And again, the studies on that aren't brilliant at the moment that I know of, but because it's not really my field of expertise, I can't really comment much further on that.
Yeah, it's a tricky problem. It's tricky to find this.
Yeah, so I'm fortunate enough to have a colleague whose expertise is placental. And so when I do tend to dabble in that field, I can hit her up for stats and her knowledge.
Well, maybe that's an initial thing to do to know if which direction you should focus in. I mean, it seems just like like you said, you're only one person. There's a lot to look at here. And a lot of confounding factors.
In fact, I've written a big proposal to actually look at all of the things you've suggested, to look at, again, further investigate why these things happen, to look at the uterus, look at the placenta. So hopefully it'll get funded.
Anything jump out at you in the data? Like, do boys have more defects than girls? Are the defects different between the two genders? I don't know. Anything that could be a signpost for you that would tell you where to look?
Again, this is a little bit mixed, because many of the studies which I have read, many of the clinical studies, they don't necessarily put sex on the results. It'll mostly be just composition of defect. And so, again, it's a little bit complicated. The ones that I have seen, there haven't been any difference between what type of defects boys or girls get. But again, the numbers are very low. The numbers that have reported it, rather, are very low, the number of studies.
Maybe you go backwards. Maybe you look for births where there was a particular defect, and then you go back and you ask for the patient's medical history, and you, of course, anonymize it. But maybe that's a way to gather a cohort without having to, do a lot of clinical work. The data's already out there. It's just not being looked at in this context. Maybe that's another way to approach it.
Absolutely. That would be a great way to approach it. So now that we understand more about, for example, heart attack and how it presents in women, this could also be a key factor. Men and women, no reason why.
So what you need is like this big lab where you're the head of it and you have like 10 postdocs all looking at different aspects of this problem and millions in funding. It sounds like that's what you really need. From
your mouth to God's ears.
Well, it's important. I mean, the whole generation of people coming and now, I mean, this is, if a lot of them are born with defects, I mean, that's a huge problem.
It's absolutely just research because, like I said, it's going to get worse. I'd like to think that it's not because it's only affects a subpopulation, women and their infants. I'd like to be not so cynical, but...
Is there, with the current coronavirus stuff, is there any funding for COVID and how it affects pregnant women? Maybe that's a way in for, I don't know, some additional funding or, not that you wouldn't study it, but maybe that's a way to backdoor and learn some of what you need to learn. I don't know.
It's actually interesting that you mentioned that because I am trying to get the wheels in to look at that as an additional study. Because, again, the data is there. I to see where it leads. Our Prime Minister's partner exited COVID, possibly even sure, and she's just had a baby.
Huh.
And I think it might have mature as well. I'm not sure. Maybe not quote me on that. But,
okay. Who knows?
That would be interesting to... I wouldn't want to frighten anybody, of course, but it'd be interesting.
Yeah. Well, very good. Is there anything that's really important that I missed that I should have asked you that you want to bring up?
Don't think so. One thing I would like was that so with congenital heart defect, 1% of the population are born with heart defect, irrespective of diabetes. And whilst a large percentage of only 30% of these cases, genetic mutation, for example, Down syndrome, which leaves around 70% maternal environment. So things like diabetes, commonly known alcohol consumption, viral infection like rubella, all these sorts of things. So gene-environment interaction, I think, really is where the focus of congenital heart defect studies are moving, or well, they already are, actually.
Okay. Well, very good. Nikita, what's the best way for people to get in contact and, provide you with ideas and help and insight and, follow what you're doing?
The best way to get in touch with me would be to check out my webpage. Or they could email me, but my webpage is at DPAG, so it's the Department of Physiology, Anatomy and Genetics at the University of Oxford. If they just type in my name there, they can find me. Okay.
Well, very good. Well, Nikita, thanks for coming on, and I appreciate what you're doing. It's vitally important, so thank you.
Thank you. Thank you for having me.
You've been listening to the Finding Genius podcast with Richard Jacobs. If you like what you hear, be sure to review and subscribe to the Finding Genius podcast on iTunes or wherever you listen to podcasts. And want to be smarter than everybody else? Become a premium member at findinggeniuspodcast.com. This podcast is for information only. No advice of any kind is being given. Any action you take or don't take as a result of listening is your sole responsibility. Consult professionals when advice is needed.